Audience across the globe. Today is a great day here. We are continuing the celebration of the World Asthma Day. And here in the studio, we have a man with great passion, a professor with over 4 decades of experience in asthma management. He has this great passion to see the life of people living with asthma transformed. He's Professor G. Rabo. He's the chief host of today's meeting. And the sub-theme for today is Insight on Asthma Education and Effective Strategies for Asthma Management. Professor, you're welcome, sir.
Thank you so much. I'm so glad to be with our audience all over the world. It's such a joy to be here with you all from all over the world. And today we are going to be looking at asthma in all its facets. And as you know, yesterday we celebrated universally the World Asthma Day, and the theme was Education Empowers. That means asthma education empowers. I have a team of people here who will be asking questions and answering the questions back. And this program is coordinated by the Asthma and Chest Care Foundation and also with the Nigerian Pharmacy Asthma Care Program. And they will be also sharing with us their experiences in asthma. We'll be having pharmacist Lawal coming to us, who is the project coordinator. And also we should be having people from Omeron who will be telling us a little bit about their nebulizer. Now, to ask some of these questions today will be mainly Dr. Corey, which we know is an anthropologist, an associate professor in Obafemi University, but someone who is also interested in asthma. Then we also have Dr. Dennis Imafido, who is the director and CEO of Apex Group of Colleges and a public analyst. And also somebody who is also interested in seeing that asthma is well controlled, and somehow he's also a pastor. Then we have a young consultants with us here who will be sharing with us in a very simple terms for the public on what asthma is. And that will be Dr. Feyike. Welcome the audience.
Thank you so much.
And we also have a senior registrar in our unit, Dr. Afolabi, who will be featuring some little bit of the challenges they have when they manage asthma. But before we open the floor, and then we have pharmacist Lawal, who will be joining us later to tell us the role of the pharmacist in the care of asthma. I just want to project a few slides here for you that would now, one of the things I want to highlight here is that the burden of asthma is a very big issue around the world. It's one of the most common chronic diseases we have worldwide. And as of now, it's assumed that over 300 million people have asthma around the world. And it's assumed that every year, 500,000 people will be hospitalized because of asthma. And it's ranked one of the 24th leading cause of severe disability in 2019. Death from asthma is also on the rise. And in 2025, we have as many people, annual death rate currently is about over 400,000. The global prevalence of asthma, many people have asthma in the world, could be as much as 400 million people, and is increasing. Now, unfortunately, asthma is decreasing in many parts of the world now because people are addressing the issue, people are This disease, I think, is increasing, although we don't have objective evidence coming on in many parts of the world. And it is underdiagnosed, poorly managed. And what is so important about asthma is that it has a global economic impact. While the advanced countries of the world are spending a lot of money to take care of asthma, the developing countries are not making asthma their focus. For several years, I've been saying that although death from asthma is increasing in many regions of the world, that death is vastly preventable. And so we're going to be here now to listen to questions coming in from the audience, questions coming in from majorly Dr. Dennis Imafidon and Dr. Korea, and then the audience. And then I will be directing these questions to those around us to answer them as a result of their own experience. So I want to hand over to Dr. Imafidon to tell us something. Can we stop sharing that?
Yeah, thank you so much, sir. First of all, we are really very happy to be here. I'd like to ask why World Asthma Day? Why the designation for asthma, and what is even asthma?
Now, the truth about it is that all over the world, from time to time, people focus on specific diseases and different months, different times, so as not to allow these diseases be buried, so that people can feel and know that there is problem in the world. And that is why Asthma Day, as many other diseases, have their particular days. But more importantly, why Asthma Day is important is that several people around the world are dying as a result of asthma because they do not have the education, the necessary education that empowers them to manage their asthma. Now, several years ago, we are finding out clearly that our goal is to allow for the self-management of asthma so that people can have the power to manage their asthma until at a certain level. So the World Asthma Day, which is highlighted once in a year, is to educate people on why asthma, what is asthma, what causes asthma, what are the triggers of asthma, and how to treat asthma, so that they can be able, as individuals, to study their own asthma and manage it.
Thank you so much, sir. I want to ask, while I was in primary school, we were taught communicable and non-communicable disease. Is asthma a communicable or non-communicable disease? And what is really asthma?
Yes, asthma is a non-communicable disease. And when doctors say communicable, they mean that you just transfer it from one person to the other. But asthma is a non-communicable disease. And in a very simple terms, I would like to say that asthma is a disease, what doctors call an inflammation of the airway. That is, in which the airway attracts a lot of things that causes the airway to swell and tighten up. And then you now find a situation in which the person is not able to breathe very well because the airway is tightening up. And that is what asthma is. Now, the resultant effect of that tightening of the airways is that people are not able to breathe, people have cough, people have chest tightness, and then sometimes it may get severe. But it is because of that inflammation that narrows the airways that causes it. Now, some other term people use is the word hyperresponsiveness. And now the word hyperresponsiveness is simple from the English language, that the airway of the asthmatics, they are reacting in an exaggerated manner to things they find around. But asthma actually is a disease of what I call nature and nurture. Nature in the sense that it is genetically transferred, from your parents and so on. Years ago, a man called Mendel talked about genetic transferring, and he talked about different ways things are transferred from generation to the other. But asthma does not follow the Mendelian fashion. That it doesn't mean that if your parents have asthma, you will have asthma. But every asthmatic must have some degree of genetic predisposition. But it can skip a whole generation. So it is not important to say because my father have asthma, I will have asthma. And then nurture is the environment that triggers up the consequences we have as asthma. And I think we'll talk about the consequences of those things later. So that is a matter of the nature and the nurture. Those are the things that have asthma. I know some people used to ask me, which is the particular genes that we can identify? But there are several genes that have been implicated. Not one gene has actually been identified for asthma.
Okay, thank you so much, sir. Nurture and nature. Well, I have another question here that has to do with spiritual tendencies. Some people, ascribe demonic attack. When somebody start grasping for breath and then start, coughing, tightening up chest, it will be as if somebody is accusing, maybe there's a supernatural hand. Are there demons involved in this?
Where doctors deal with empirical evidences that are measurable by simple things. We are not into the realm of the spiritual. We don't know, so we cannot even talk about that. But empirically, we know that if you have a gene, genetic predisposition, or some markers, what I call, like if you're having your family allergies, like allergic rhinitis, they have cataphones, allergic conjunctivitis, they have red eyes, allergic pharyngitis, they have sore throat, and they have family members who have asthma, they are more likely to have asthma. And if they have environmental factors like triggers, whether there are spiritual components on it, it is beyond the level of the average doctor to decide or discuss.
Wow. Thank you very much, Professor. You just made mention of empirical evidence. Yeah. I want to ask, sir, how do we know that somebody has an asthma? Okay. And who is competent to tell us that somebody has an asthma?
Maybe I would, in order so that the audience may have a bit of a more clearer means. Let me ask Dr. Feyi now. In your experience as a pulmonologist, although you are just climbing the ladder, can you answer that question so that the audience can?
Thank you so much, sir, for the opportunity, and thank you for that question. Going to knowing how somebody can, to know whether somebody have asthma, it is a combination of looking at the presentation, what we call the symptoms that an individual presents with, which means, does this person have cough? Has this person been having some form of chest tightness, which we call their cardinal symptoms? Are there instances which this person have noisy breathing, which we know as wheezing, which are some of the key symptoms that a patient with asthma will present with? Do they have allergies, which Prof has described earlier on, itching of the eye, sore throat, and then some even react to some foods, food allergies. Do they have family history of asthma? So those are the questions we want to ask from the symptom in terms of the presentation. And then when such an individual presents to us in the clinic, we want to examine this patient apart from taking history. We look at the examination component, but in some instances we may not even pick anything. But sometimes we could pick features of some skin rashes, we could point out to allergy, we could have brownish of the eye discoloration. And then we now go on to do some tests, majorly which we know as spirometry. That's measuring some components of the airway. How much of air are they able to bring out to test if there's some form of obstruction to flow of air in this person that is presenting with this symptom?
Yes, I think Feyi will show us some of this demonstration in the later part of the discussion as we go on. But there's one thing I want to say. There's a man, I don't know if he's still alive, someone I know very well in the American Thoracic Society called McFadden. He wrote one of the earlier works on asthma, and he said, if anybody does not have nocturnal attack, then it's not asthma. As one of the big things about asthma is that when people have symptoms like this, it is more in the early mornings of the night. Now, some people say maybe because there's what we call the circadian rhythm of the body and the morning tends to lead to narrowing, Maybe there are trigger factors around the bedside, but that is so important that it is nocturnal attack. Then the other thing is that the attack can be episodic, that is, can just come up, or sometimes it can be continuous. And it may run like that early in the morning, then wanes, and sometimes it can continue depending on the severity of the asthma. But one important thing we need to know about the asthma is that it runs by modal pattern. That is, in those days, when I was in medical school, we used to talk about early asthma, late asthma. We used to talk about intrinsic and extrinsic asthma, but those terms are no more used. That it is childhood asthma and adult asthma. So some originate in childhood and some originate later in the year. So as Dr. Feya has explained to you, the symptoms with the expression of the disease in terms of the external allergies, instead of how it looks in the long way, instead of the pattern of the disease, will make us say this person has asthma. Then we can then go and do a spirometry, and that's where the doctor comes in. And I think Feyi will show us one or two ways it is done, and then we're not going into details so that you can get to know it. Thank you.
Thank you so much, sir. When you were talking, you mentioned something about triggers. What are some of the triggers of asthma?
Yes, I think Dr. Falabi can tell us a little bit of some of the triggers from his own experience in the clinic of asthma triggers.
Thank you very much. The triggers of asthma, they are many, and they are environmental factors that exacerbate the symptoms of asthma. And these triggers include dust, smoke, respiratory infections like pollen stool. These are triggers that actually exacerbate these symptoms. And whenever a patient comes to the clinic, we usually ask them about their triggers. And these triggers also include exposure to cold weathers. You know, most of our patients, when they come to the clinic, they complain that, you know, they used to have their symptoms at night or early hours of the morning.
Yes, I think you are right. So what he's telling us that there are indoor triggers and outdoor triggers. There are environmental triggers which are specific. They're also non-specific that can cause it. But you see, over the years, all over the world, one of the commonest trigger is what they call the house dust mite. It's not just the house dust, but the mite. Very small, can only be seen by a microscope. And large percentage of people have asthma, that is the trigger factors in them. But it varies. What I mean idiosyncratic, that some people have it and it's not, others don't have it. Some are inciters and some are actually inducers. So if I'm to look at it on a wide base, one, exercise can give it, physical exercise, emotions, you know, when you're angry, even pregnancy can trigger out attacks. Then drugs can also, even thunderstorms. Thunderstorms have been able to, I know that they cause the break of pollens and are scattered and hail. Then pollens, seasonal changes. So all these things are many, and they are triggers of asthma. I don't know if you want to add one more that you think that you have in your own experience.
Well, thank you so much, sir. Some of the things that can also trigger asthma, alongside with what Prof has mentioned and my other colleague, is that we have some chemical irritants, occupational sensitizers. You know, patients who work in paint industry or they work with chemicals, pungent smells, even detergents. So these are some of the things that can actually trigger.
Yes, that's very good. That's what we call the occupational group of occupational asthma, which is another group of asthma that is important. Yeah.
Sorry, sir, I want to find out, does this asthma have a cure? Or can we have immunization, just as we have polio immunization against this asthma?
Well, you see, in medicine generally, we always talk about managing a disease. Well, I know that there are some communicable diseases that can be eradicated. We know there are certain diseases that can be eradicated. But I don't think in asthma we use the word cure. We use the word management of the condition. And I'm sure Faye can tell us, in asthma we use the word control rather than cure. We say control and not controlled. Faye, let us know some of the factors that you use to assess control in asthma.
For patients who have asthma, oftentimes when they present to us, we want to assess them to know that to what extent the symptoms they are presenting with is actually that being significantly being reduced, or sometimes some of them may even have their symptoms being completely being resolved as a result of the treatments that we give to them. So when we say a patient has good control of symptoms, we want to know to what extent the symptoms they present with during the day, not just like we talk about the diurnal variability of their symptoms, to what extent are their day symptoms being removed? And then want to look at their nocturnal symptoms. To what extent are the nocturnal symptoms have been resolved in them? And then we look at how much of limitations in their daily routine activities is asthma impacting on? Are they able to go to school? Can they do their normal job? Is it really limiting them? They want to look at to what extent or the frequency to which they use their reliever medications, to relieve their symptoms. So that are the things we consider when we look at asthma control. So for someone to be controlled, that means they are free of their daytime symptoms, they do not have nighttime symptoms, they are not limited by their asthma, and they do not have frequent use of this reliever medication.
Yeah, I think Faye is a very brilliant doctor, but I would like to make what she said in a more simpler way. Now, when she talked about nocturnal symptoms, she means the symptoms they have in the night. And it's a simple question we normally ask. How many times do you wake up in the night because of asthma? And how many nights do you wake up in a week because of asthma? And if these things are increasing, it creates a lot of problems. And when she was talking about limitation of activity, it comes from working, you know what I mean? Do your household chores, even speaking, even do your activity and do like a businessman moving from place to place, supervising your school. Is your work limited? So all those things are important in assessing it. Then when she now talks about the symptoms, she now says, well, are the symptoms increasing? But more importantly, and we're talking about that more, when we look at asthma, there are drugs we call rescue medications and other drugs we call preventative medications. Now, the rescue medications are the drugs we give, and it's changing in our thinking, and we'll talk to you about what we're doing now. Now, we use those relief medications, it relieves it. Now, if you are using more of that relief medication often, that shows your asthma is not controlled. If you are using an additional inhaler because you are not controlling your asthma, that shows your asthma is not controlled. But then there's another thing we also use to measure, and that's the peak flow meter. I don't know if you can give me one of them. Now, this is, without exaggerating, sometimes I say to people that just as the sphygmomanometer, that is what you use to measure blood pressure, is to the hypertensive, so the peak flow meter is to the asthmatic, but it's not doesn't do it. Now, this is a small instrument in which we advise every asthmatic to get, and they measure the asthma in the morning and the evening, and they can chart it. So when the reading becomes bad and is decreasing rather than increasing, we now say that this patient is not controlled. We don't like to say poorly controlled or mildly controlled. I don't like it. I like to say well controlled or not controlled. Because if you say mildly controlled, it gives you the false belief that you are still okay. For me, it's all or none. Be controlled or not controlled.
Wow. Prof, we are learning every day, and I think today I have learned something great. You have been listing, adumbrating what professionals do to help people living with asthma. Is there anything an ordinary layman can do to assist people living with asthma? Is there anything?
Faye, I don't know if you can take in that question.
For the management of asthma, most times we say it's a shared care approach, which means it is not just the physicians. So both the patients who have asthma and then people around them, either relatives or friends, are actually supposed to be partaker of partnership, in the management of asthma. What people around can do to help in management of asthma, one is that they have to understand basic things about the asthma. One key thing is what we call the triggers, which I've been talking about now. Take for instance, the mother has a child that has asthma. That mother has to really work with that child to know what are the things that trigger this child's asthma, or even a teenager. So sometimes individuals don't even know what their triggers are. So one of the things they do is that they should go ahead, work hand in hand with them to know what their triggers are, and then help them to avoid these triggers. Then another thing is emotional support, because there's a lot of stigma for people who have asthma. I don't want to go about with my inhaler, so they need emotional support, and that is also things they can do. Then people around should also understand basic first aid therapies to do for people who have asthma. If somebody around you have asthma, you should behave and don't have an asthma flare. You should be able to ask, do you have your inhaler with you? Sometimes they are not even able to control themselves to be able to puff off this inhaler. So someone around who have asthma, you should be able to assist that person, get their inhaler out of their pocket, which sometimes we are encourage them to go about with their inhalers oftentimes, puff it up, and then as quick as possible, if this patient is not getting the relief, look for the nearest hospital to move this patient into to help them relieve their symptoms.
Yeah, there's some more. Yes, I agree with what Faye said, but one important thing that leads to poor control of asthma is what we call the inhaler technique. The inhaler is so important, it's so central to management of asthma, and I will talk about that when we talk about management. The reason is this: when you use the inhaler, it's a very portable device, and when you inhale, it goes directly to the airways, rather than going around the normal body system of distribution of drugs. So its bioavailability to the airways is important. Now, if this inhaler is not well used, the tendency is that some people will just take it and puff it up is a big problem. So that you as a caregiver, you as a family member, you must make sure that you know about this inhaler technique, and then the person knows about the inhaler technique. Also, the ability to know some of what I call the prodrome that can be, that sort of points to asthma. If you have a child, if he's having sneezing, if he's having a running nose, if he's coughing, if he's getting breathless, he cannot do his work properly, if it's what we call, what we normally say presenteeism, he goes to school but he's presenting there but he's not doing anything, or there's absenteeism, he's absent from school. All those things are pointers, that this patient is not doing well. So you don't wait for the emergency to come before you now start to act upon that. Then the use of the medication. Asthma medication has changed over the years. And I don't know if you can tell us one major change in asthma education treatment.
Thank you so much, Prof. Over the years, there's been a lot of evolution that has taken place in the management of asthma. And one of those big changes is that we do not use what we call the short-acting beta-2 agonists alone, the common Ventolin or salbutamol that people are used to. So there's no more room for the use of Ventolin alone. And in the management of asthma, there is this step care management approach that we use. And then the global initiative for asthma, which is the global body that coordinates asthma management, they do this yearly release of what the management of asthma should be. So there are majorly two pathways, and we have the preferred pathway, which deals with the use of what we call the low-dose inhaled corticosteroid with a formoterol component. Why formoterol?
What is formoterol?
Yes, sir.
What is it?
Thank you so much, sir. Formoterol is a long-acting beta-2 agonist, but it's
What's a
very
long-acting beta-2 agonist?
All right, sir. In asthma...
Yeah, right, go on.
In asthma pathophysiology, one thing that is...
What is pathophysiology?
is that Patients with asthma, they have narrowing of their airway.
Okay.
So majorly the what we call the bronchus, which is like the air pipe through which air goes in. So these medications, what they do is that they help to open up the airway so that there will be enough of air going in and then coming out freely without any impediment or resistance to flow of air. So that is what these medications do. Formoterol is very unique in the sense that apart from acting for a long time to provide a long relief within the airway, it also acts fast. So it's able to subserve the function of Ventolin or salbutamol, and this prevents exposure of patients with asthma from being over-reliant on short-acting beta-2 agonist, which has a lot of side effects. So what we use now is that we use what we call the mat therapy. So using one single inhaler, both as their reliever and then as their maintenance. And then it also enhance compliance and adherence to asthma.
Yes, I think Faye is a very brilliant pulmonologist, and what she has said is good. And if I can explain it simply, in the past, people look at asthma as basically a disease that narrows the airways. So what we call bronchospastic disease. And so everybody wants to open the airways. And then we have drugs like salbutamol. Now, that beta-2 she mentioned is because they're in the airways. And when we use the beta-2 inhalers, they narrow the airway, they open up the airways, and they make things difficult for the patient. I mean, they make it easier for the patient. So, in asthma, those inhalers were important. But over the years, we have now found out that if we use that inhalers very often, it will increase the airway hyperresponsiveness. That is the way the airway responds to asthma. And it will upgrade those factors that narrow the airways and downgrade all the factors that that causes it to widen up. So you have, in simple ways, up regulators, down regulators. And then it's a cause of death from asthma. So research over time has changed from the use of those kind of drugs as a single inhaler. We now use a combined, what we call the MAT approach, maintenance and reliever therapy. Now to maintain, we have to use a drug, as I told you, that causes inflammation, opens it up. And also, we have to use a drug that widens the airways. And now he mentioned to you that there are some drugs that are combined both. So that is the MAT approach.
Thank you so much, sir. In fact, I think a few years ago, I heard a doctor say salbutamol that's very good for asthma. But now, just as we have the ACT for malaria treatment, a combination of drugs, now we have a combination for drugs too for asthma. Day before yesterday, Prof, something happened in one of my schools. A student suddenly started, gasping for breath. And then some of my staff went there to see how they can rescue the situation. And we observed that, this person it's not supposed to be for cold, because we saw the jacket, more sweater, jumper, and all that. I want to find out, does heat actually cause, is it one of the triggers? That's one. Then number two, although I've approved the purchase of nebulizer, where does this nebulizer come in? In our sick bay, right? We observe that, it's good for us to have a nebulizer so that we can stabilize cases like that. Are there also simple first aid that schools across the community should have for patients of asthma? Yes,
I will answer a little bit, and I will want for you to talk to us about how you manage an acute severe asthma. That's a very different approach as how you manage asthma that comes with episodic things. But before you come to the situation where you say the asthma is acute and severe, or if I define it in a very simple term, is the asthma that does not respond to its regular medication. And we need more dose or more drugs to attain to the same level of control. And actually will disorganize the normal routine of the patient. And sometimes it can lead to the asthma, to patients getting more severe, and some cases, unfortunately, to death. But there are things you must watch out for. If you find out that your symptoms are increasing, despite the fact that you're using your drug, that is your cough, your chest tightness, your wheeze, that is a very bad sign. If you notice that you needed another additional drugs to maintain the same level of control, that is also a very bad sign. When you notice that you are now waking up more times in the night, one night, because of your asthma, that is not a good sign. And to now notice that you have to make up more nights in a week, that is not a good sign. Especially if those who have recently been discharged from the hospital, that window period, some of them were not well discharged, some of them were not well controlled, or some of them were discharged well, but they're not using their drug, that is also a very difficult situation. Then the inhaler techniques. The person may not be using the drug very well, or maybe using the wrong kind of inhalers. That is also very bad. Then the triggers. Let me give you a very simple example. I used to have a patient in the hospital who we were treating, and actually for acute asthma. And I was surprised that this patient was not recovering as much as I like. Then I said, look, we have to look into this. Then the patient told me, and this is where I said that one of the big things for physicians and pharmacists and nurses in this program, please listen to your patients. Listen to your patients. Don't assume you know everything. And then this patient told me, look, I want to go to the nearby hotel. Sir, after treating me, I go to the nearby hotel and I'll come back. I said, why will you did it? So he kept on emphasizing it. So I said, when I go back to the nearby hotel, we'll treat you and you come back. Within 2-3 days, he was well. And I began to find out that that hospital was, we were painting the hospital at that time. And the man was reacting to some of those things. So the environmental factors are important. Going to a new environment, the seasonal changes, all those things must be factored in when you want to say the patient has acute severe asthma. Now, Faye, you have an experience as a senior registrar, work in 2 or 3 hospitals, and then as coming in now to join us in our team as one of our consultants. How do the patient present and what do we do? We may not go into details, but just a few things.
Okay, so thank you so much, sir. For patients with asthma who are presenting in what we call acute severe exacerbation, because exacerbation varies in severity. Some can have mild exacerbation, which may not really warrant them to presenting maybe in the emergency department. But when it is severe enough for them to present in the hospital, the first thing we want to do is that we want to stabilize these patients. Because at that point, their symptoms are very severe. They are gasping for air because of the narrowing of the airway that Paul spoke about earlier on. So the airway muscles are tightened, they have noisy breathing, they are coughing, they are agitated. Some of them find it difficult to even sit in a place because there's low level of oxygen in their blood. And for this patient, when they come in, we want to really monitor them. What is important is that we want to relieve that obstruction to airflow. And what we use is what we call the bronchodilators, which are the things that open up the airway to allow air to go in and out freely. Another thing that we do is that we measure the level of oxygen in their blood. Oftentimes, they have low level of oxygen. So we sometimes want to give them oxygen supplementation to make sure they have enough of air for them to survive. And then other thing that we do, because of what was earlier mentioned, that they have a lot of inflammation, the airway is swollen, a lot of mucus production and the likes. We give them what we call the anti-inflammatory medication, which are the steroids. In this case, rather than giving them in terms of the inhaled form, we give it either orally or through the intravenous route to suppress the inflammation. Once they are relieved, most importantly, we want to assess them before we discharge. We are not in a hurry to discharge them. Before this patient goes home, we want to identify what actually led to this exacerbation. That is identifying the trigger, because a patient who have an exacerbation is at increased risk of future exacerbation. We don't want them to come back again. And then we want to educate them on the basic inhaler therapies. We advise them to get a peak flow meter, which was demonstrated by Prof. earlier, for them to monitor their symptoms at home so that they know when there are features of such exacerbation that are about to occur in the future. And then we counsel them to adhere to their medication use, and then we book them for clinic follow-up so that we can monitor them.
Yeah, I think this is one of the best explanation I can think anybody can give. Can we have the volumetric? Very best explanation anybody can give. But I just want to add a little bit of some light to it. Now, there is what we call a spacer device. Not many people can get a nebulizer. Not many institutions can get a nebulizer. But research have found out that this is called volumetric, but all it means is just a spacer device. And then here you put your inhaler, and here the person puts his mouth. When you press the inhaler, we'll not be able to give it this, but I'll click we do it. The person breathes in. The truth about it is that when you use your inhaler, it is the smaller particles that go in straight into the airways. The larger particles get deposited in this place. So the percentage of inhaler that come to your airway is increased. So without the volumetric, some of these inhalers are wasted in the mouth. Now, but what a nebulizer does is to increase the volume of inhaler that comes to the airways. And it's especially very good for those who are challenged, that they cannot coordinate properly, or those who are young, or in certain emergency situations. Then again, she talked about oxygen. Now, for the professionals here, there's something I want to tell about oxygen. Oxygen is a drug. Many people think that oxygen is just something, it's a drug. So you have to prescribe the dose, you have to prescribe the route of administration, you have to prescribe the duration of administration, and you also ought to monitor the response of the body to oxygen. And we do it two ways. Either we check the blood, or we use what we call pulse oximeter to look at the saturation. Now, in the past, we used to give a large dose of oxygen, but we don't do that now. We need a moderate dose oxygen, which you can give in form of a mask or a nasal cannula. Now, the masks, we don't usually give it very often for some because they can be claustrophobic. Whereas some people don't like closed space. And then they may have problem of rebreathing their air again. So we give them a form of a nasal cannula. And then we monitor how they are doing. Importantly, she talked about steroids. I can tell you majority of patients that I see that have died of asthma, or not the majority, quite a lot, is that people keep on giving them these inhalers. And there are two kinds. One that we know is the common beta 2. The other one is the anticholinergic, which we cannot talk now. But they don't give steroids. And when I defined before that, what causes the narrowing is mainly the inflammation. And the narrowing is an expression of the inflammation. And so because that is the situation, you need to give steroids. Now, one big problem we now have in many developing countries is that people quickly go and give them antibiotics. Now, in the past, we do not encourage antibiotics. But now we now know that asthma can be triggered up with infections. What we call the mycoplasma infection or the strep pneumonia or things like that. But it is not so central to the management. Then the other problem people have is to give them aminophylline. And I see that in many pharmacy many hospitals, people give aminophylline. Aminophylline as a first-line management is dangerous. It can actually lead to death. Because doctors have what they call a therapeutic window. That is, the drug needed to relieve a person, or the dose needed to relieve a person, is also the kind of dose needed to cause complications. And so most people, when they use aminophylline, we tell them to try and look at the theophylline level to measure it, and it's not done. And then there are other effects. So aminophylline does not form first-line management of asthma. I used to tell my students, if I ask you how do you manage asthma, remember SOS. Why S has to do in those days with salbutamol, breaker to oxygen, then steroids. It is when the patient is not responding that will go to something extra.
Okay, thank you so much, sir. I was going to ask that with you mentioned some drugs now, aminophylline and all that, with the departure of some multinational pharmaceutical companies from this country, and considering the current economic realities, how will a typical asthmatic be able to manage asthma in the midst of all this?
Yes, I want for you to talk about some other alternate people. I want to pause, first of all, to thank the Just Farmers, for supporting this program. Though this is a public program, so we are not featuring any drug company, but they were supportive in terms of logistics, not finances. And why I actually accepted their support is that in terms of the logistics, that is supporting us and making sure people receive this program, not in terms of financial logistics, is that while the GSK has left, Just Pharma has come with drugs that are similar to the drugs that are being used by GSK. And she will tell us some of them, although we are not allowed to talk about drugs particularly, but because this is available. We also want to thank the Omeron Group for their being here and because they take care of peak flow meters and nebulizers. And they are also in support of the work we do. Then the Pfizer is also involved in vaccine. Again, logistical support, because vaccine is very important, especially for patients that have COPD and chronic asthma, because we know that people that have pneumococcal disease, influenza can trigger. So such patients, we need to get them. So tell us about the alternative therapy and maybe, the other drugs we now have. And maybe after that, we can now go over to pharmacist Lawal to talk to us about the role of the pharmacist in asthma.
Thank you so much, sir, for that important question. One of the challenges that we have in this part of the world, that is, the low to medium income countries, of which Nigeria is inclusive, is the problem of affordability and availability. Over the years, this has been a challenge, but this became so much important with the exit of one of the multinational companies like GSK from Nigeria. But with the help of some of the drug companies that have been coming in, we now have some substitutes that we can use that perform the same similar function. An example of it is the Saltrol that contains what we call the salmeterol and the fluticasone, which is the same thing that is in Seretide, which GSK markets before their exit. Something that we also have as an alternative is the Fortide, which contains the formoterol that we spoke about earlier on, and then also has inhaled corticosteroid, which is budesonide. Although some other alternatives are available, but those are not so readily available. These are things that we commonly have in our environment that patients can use and are also effective as what we used to have with GSK.
Yes, I don't know if Ms. Lawal is online now. I don't know if she can talk to us a little bit on the pharmacist's role, and then she also want to talk to us about her vaccine center. And after that, we'll have a short remark by the Omeron Group. Over to Pharmacist Lawal. Pharmacist Lawal is a very enthusiastic person in asthma, and she is the project coordinator of the Nigerian Pharmacy of Asthma Care Program. And also she's involved in hypertension, and she's a foremost person in pharmacy in the country. She has Victory Pharmacist, a pharmacy that reaches out to people around the country. Over to you, ma'am.
Good afternoon, everyone. Yes, I think it's echoing. Can you hear me?
Yes, we can hear you now.
Can you hear me?
We can hear you now.
Oh, okay.
Please, if there's another device with you there, off it. Just concentrate on one device. So that will stop the echo.
I have only one device.
All right, go on.
So I don't know where the echo is coming from. Good afternoon, everyone. It's been a very interesting session, and I'm sure we're all learning. So I am the project coordinator for NiPAP. NiPAP is Nigerian Pharmacists Asthma Care Programme, a baby of the Association of Community Pharmacists of Nigeria. It was put together by our National Chairman, Pharmacist Wale. I guess it's in-house, so he might also be able to answer some questions. But this afternoon, I want to just briefly run us through what we as community pharmacists can do in asthma care. I'm sure we have all gotten more information about asthma, and we are all seeing that everybody
off me on the screen and see if they can
the
put her on the
other
screen?
professionals have their roles to play.
Okay, but they remove me from the screen now and put the asthma
The
or
first
something.
point of call by patients, those who have been diagnosed, those who are not been diagnosed, they usually come to us first. So it's important that we are able to help, and that is why NiPAP was born, so that we can empower community pharmacists to do more for asthma patients and have a healthier Nigeria. So let me start from saying that about 20% or more of those who are living with asthma are yet to be diagnosed, and a number of them present at the community pharmacy. So when they present, we look out for symptoms that are suggestive of asthma and point them to where they can get their diagnosis, and then work with the physician who is taking the diagnosis to help them assess care. So we come in there strongly. And I will also say there are some patients too that they don't even have this asthma. Somehow they've been diagnosed wrongly somewhere, and there are medications that they do not need. We're able to also help there. I recall some years ago, there was this patient that said their name on. He went to inhaler for about 10 years, and that particular day, nothing was working for him, nothing. He had been to different places. So, long story short, we referred him, and we found out that he didn't even have asthma in the first case. Whoever made the diagnosis when he probably visited, I mean, sometimes some people self-diagnose, or a friend will say, this is what you're having is similar to what I had, this is what I did, and things like that. It also comes up there from me. This particular patient had what we call the hypertrophy, which is a form of heart condition. Then, working with asthma patients, we engage patients and their caregivers on their condition, help them also to look out for their triggers. We also educate on, especially the drug aspect of the medications. Some of them are not taking their medications because they have fears of side effects. So we take them through, and then some of them are not able to afford their medication. Some of them don't even think that they should just take this medication because they don't want to be on medication every day. So we have them to understand why it has to be every day that they are on this medication. And there's one thing that is one of the current trends in asthma management. Every asthma patient should have an asthma care plan, and that care plan is usually developed with the physician. The physician would have broken the management into 3 stages. You know, when things are normal and the patient just continue, when there is moderate problem that can be managed with the pharmacist, and when there's a red alert that you must rush to the hospital, and what to do. So there's a plan. And then when we identify these patients and they have their plan, we walk through their plan, we support to provide that support for them. In drug therapy, let me set an example. Where the patient sometimes you would just apply eye drops and it triggered the asthma. So it happened that that eye drop was a beta block. It's not a class of drugs called, yes, it was just applied to the eye, but it triggered the asthma. So we have our patients to look out for drugs that may trigger the asthma. If possible, we work with their prescriber to say this drug will trigger their asthma so that they can have alternatives or suggest alternatives. We also
I was
help our
thinking that
patients
is she not
to
on?
properly use
She's there
their
now on
data.
video.
You know,
She's not there.
learning
She's
is a continuum. They can't learn everything at once. So every time they visit, as much as
What I'll
we
take.
want to see them demonstrate that they use their inhalers, and I'll take advantage of this to say this cooperate, because for some people just think that we are doing over there, but it's important that we see how these inhalers are used so that if there are any lapses, we can help. But sometimes we are not getting control because we are not using the device properly. For now, we know that we have spacers that can help to deliver the drugs better. So, and for those who are on daily prevention inhalers, you may need a spacer for every day use. And then how do you keep your spacers full? That would be key so that it doesn't give you infection. So these are all the areas where we form up. And we're usually handy, you can be reached at any point in time to help out. And then in case, like we are partnering with the Chest Foundation, Asthma Chest Foundation, today we are partnering as Association of Community
When we
Pharmacists
finish, towards the end, you let me come and share this my slide. I show them a few things.
We know that education is key. Knowledge is power. And the more educated we are about our condition, the more we are able to help. Now we are able to help with our condition. We also help to identify vaccines that may be useful and discuss this with the patient and the GP managing. So if we let's go ahead, we also have vaccines that we can provide for the patient. So in a nutshell, what we do is to complement what the GP is doing in management of asthma. We focus on the patient, we want to help the patient to not have a breakdown or no attack. That's where we are. We want to have patients that are on top of their asthma associated. So we are available to help, and we have a body that is caring. We are getting training. Professor Rabo is one of our trainers, and we are there for Nigerians. Thank you.
Thank you, but we would have loved to see your face. Why not show your screen so that the audience can see you? Yeah. Can you focus on her now? Pharmacy Lawal is of the Victory drugs, and she's a very, very efficient, pharmacist, and also a very gentle lady who is interested in helping people. She's she can take a lot of energy, and so I want to say that she's even the prime mover from the pharmacy world on this project. So we want to thank you for what you have done. And then she also have a vaccine clinic, and vaccines are so important in this country, especially both for the young and for the elderly that have chronic diseases. So I think you can always contact her and also the pharmacists of Nigeria. I don't know if the Omerian rep is around to talk to us a little bit about their nebulizer. Just a short thing before we now take questions from the audience. And stop sharing now. Stop sharing. Yeah. No, first, yeah, okay. Yeah.
Hello, good morning, sir. Good morning, ma'am.
Good morning.
Everyone.
Okay.
My name is Taiwo from New Heights Pharmaceuticals, and I will quickly like to share my slide. Please allow me to just share a slide, please. I'm going to be brief.
Yeah, you have been allowed to share now.
Good morning, Prof.
Yes, thank you. Good morning, yeah.
Good morning, Mama. Good morning, pharmacists, and good morning, everyone. I'm starting on the existing protocol. I'm just waiting to be allowed to share my.
Chief Controlling Officer, please, can you allow? Okay. Chief is there, yeah, okay. Okay, yeah, go on.
Please, can you all see my slide now?
Yes, we can.
No, we can't see it.
Yes, we can. You can see my slide now.
Yeah.
You cannot see it, so can I go ahead?
Go ahead, go ahead.
All right. Thank you very much. All right, I said earlier, my name is Taiwo Ladito. I'm the product manager for New Heights Pharmaceuticals Medical Devices. And briefly, I'm going to talk about the nebulizers, the hormone nebulizers. So nebulizers are devices that we use for giving medication to them so that they are delivered directly to the site of treatment, site where we expect them to use at the lungs. And with us, we have
Do you have any other questions?
Yes, I want to ask you to talk about our Asthma Care Foundation. What else do we do? How do we get partnership?
That's good. I'll go to that one, yeah.
Then I will ask you a question on how do we go to hospital? Is it the primary healthcare? Is it the secondary?
Good. Go.
Dennis.
Is there, what question do you want to ask again?
And also we have
if there's any other platform or events for reaching out.
Correct.
There is also
Okay. Right. That's okay. So, no, there's no. Can we ask any question online?
Medium particles and smaller particles of different various sizes.
Then to write the question online for us.
We have medium particles.
Any more questions online?
Into the mid airways, and we have an nebulizer key being able to deliver smaller particles into the lower airways of the lungs. So our nebulizers, what we need to know about our nebulizer is that they have ability, our mean mass aerodynamic diameter, our aerosol output, and our aerosol are significant in our hormone nebulizers, and they meet the expected European Respiratory Society and European standard specifications. And these are very important when you are deciding to pick a nebulizer. Hormone nebulizer meets the demand, expectation, the aerosol output, and also the aerosol output rate. Now, the hormone nebulizer rate is in how many meals of medication is being delivered per minute. Also, it's saying how many meals that you actually get into the lungs. So the nebulizer rate is approximately 0.5 mil per minute, and then the output rate is 0.4 mil in a minute. So we are telling you that you have the best efficient nebulizer when you are delivering medications to the lungs for your patient. It's also important to note that our noise level, the device noise level, the portability of the device are important when you are choosing a nebulizer. With common nebulizers, they are noiseless, they are very quiet. You can nebulize a baby, you can nebulize children, it's not bulky, it's not noisy, so it's easy to carry about. Maybe you're traveling, maybe you're moving from one area to another, you want to have a go around nebulizer. We have nebulizer that fits that purpose. Benefit of a nebulizer is that they deliver directly to the lungs. They allow high concentration of medication, so there is no medication waste. So wastage is a factor that been pulled out when you are using a normal nebulizer. Then you have greater clinical effects with less medication need for the patient because you're actually getting the best for the patient when you are nebulizing. Nebulizing with our own nebulizer can also lead to better treatment than using inhalers alone alone. Then no specific inhalation combination is especially required when a child or an adult is using nebulizer. So when you are nebulizing the medication, whether as a doctor, whether as a nurse, whether as a pharmacist, or as an end user too, personally, you are sure that you are getting the best based on the medication the healthcare provider has instructed for your management. So we can also mix different medication in our common nebulizer. The kit has up to 10 meals graded allowance that can allow for medication dilution, medication mix in the management of the patient. What are the important things to remember? Remember that you must consult your doctor when you are actually going to use a nebulizer. You need to get your medications, you need to get your prescription from your doctor. You need to also clean your nebulizer before every use and ensure that if every time you need to use your nebulizer is in the pocket where
Tell that lady to give me copies of my asthma book and pamphlets fast. You can do book and pamphlets.
And get a reset for the next nebulizer point for the next patient. No essential oils can also be used with nebulizers. It's advised that you don't use essential oils on the nebulizers. We have different types. We have the compressor nebulizer, we have the hospital nebulizers, we have the compressor nebulizer for home use for adults and children with different max size. We have the mouthpiece, we have the nose piece. On our compressor nebulizer, it comes with low velocity medication flow, so it allows for easy to breathe in and breathe out and coordination for patients. It's easy to use for children. I've said that they are very reliable and very efficient. The nebulizer kit comes as is forced through the nose, so there's a technology behind it, and you are getting the best. This slide is trying to explain that. The compressed air trying to get through the barcode, you are getting the sterile air through your nebulizer kit, and then your medication is turned from liquid into aerosol, and then efficiency can change.
Yes.
We also have the mesh nebulizer. It's easy to carry about nebulizer. So it can be put in the pocket and nebulize in any position. It's easy to use, it's portable. Technology behind that is a bit different from the compressor nebulizer, but it is easy to use. You can put your medication in the medication pot and you can nebulize in a different position while sitting, while lying down. It's very quiet. You can even nebulize in the brain, and it's portable and very silent. So you can put it in your pocket and it's easy to carry about.
Yes.
Lastly, I want to talk about the health check spacer devices. These are devices that you can also use in combination with your inhaler. It allows for adequate dosage medication to the lungs.
What is her name?
Avoid oral drugs.
Her name.
Reusable.
Her name. What's her name?
And it comes with 3 masks. We have the infant mask, we have the adult mask, we have the child
They will
mask.
write it. They will write it and bring it here. I was told you to write it down.
Comfortable and it's affordable. So at this point, I want to say thank you so much for your time, Mark, for that. Thank you, Prof. Thank you for this time, and happy World Asthma Day.
Yes. I want to say that, what do you call it, pharmacist Taiwo is a professor of nebulizer. And the nebulizer is not only for asthmatics, they also do blood pressure devices, and they also have do nebulizers for hospitals, clinics, and so on, you can always contact them. And we are gradually coming towards the latter part and soon end this meeting. I think I want to give pharmacist Lawal to just say a little bit shortly on stigmatization. And after that, I will give Dr. Kehinde to say something about the asthma plan, the what you call action plan. Then we shall go back to 1 or 2 questions from Dr. Victor Kore and Dr. Imafido, after which I will now take all the questions online and close up. So please, anyone's answering questions now could just be as brief as possible. Over to you, Pharmacist Lawal.
Thank you, sir, for having me again. So I want to talk briefly about stigmatization, which is an experience that we have as far as asthma is concerned. Many of the patients, they have that fear of stigmatization, and sometimes it drives them into self-denial. So we need to, as citizens of the country, we need to, as caregivers, we need to help them to come out of stigmatization. We should not allow it. We should encourage them. They're not sick. They're not handicapped. So we need to help them to understand what their asthma is. I'm saying this with all passion because we have. I remember some years ago there was a patient we lost because he didn't want to accept being an asthma patient. Each time he presented the symptoms as suggested, he called it to see your doctor, said no, for his enemy. At the end of the day, this patient also had hypertension, and the doctor placed on beta blocker. So it took his time. It triggered this asthma. And we said, look, it's likely that you have asthma. Go see the doctor. He said, no, we found out later that he just stopped taking all his medications for blood pressure as a solution to that problem. And he ended up with a stroke. And we lost that patient. That was many years ago. So we need to look at many things that we can do for the asthma patient. They don't want to be stigmatized. I mean, people living with asthma. So we need to encourage them. Please don't be in self-denial. Talk with us, we'll help you. We'll support you the much we can. Thank you.
Thank you very much for that profound discussion on stigmatization. I want to add to say that, well, it may not be a research that is accepted by everybody, but most of us know that when you compare the asthmatic as a cohort, as a group, to general publicity, they seem to have a higher IQ. And asthmatics have been great in the service of the earth. Clinton has asthma. So many great asthmatics. So it is not a disease that you should be afraid of. To say that, well, I'm going to die soon. You will live your normal life. You will live your quality life as long as you follow the necessary guidelines. You know, many people, many famous men living have asthma. In fact, footballers, athletes have asthma. So they say, well, asthma cannot run. No, you can't. They have won marathons. And when you take your preventative therapy, you can do anything. And that is why this year we are focusing on education. Education empowers. Somebody said that the word doctor is derived from the word education. To educate, to educate, to educate. And I tell my medical students, tell my residents, you must educate your asthmatics. It's not that you should just tell them what to do. The education should be bi-directional. As you listen to them, they listen to you. And then you come at an agreement. And now in asthma, we're talking about self-management plan. Now, I want to tell Faye now to talk to us a little bit on the action plan.
Thank you once again, sir, for the privilege. The asthma action plan is one of the components of the asthma self-management plan that really allows patients to be part of the management process of their asthma. Written herein is some basic components alongside both the patient and the physician. And this contains the patient's details, the managing physician's details, the phone number, emergency contact, that in case there's an asthma attack, who do we contact? And then on this written asthma plan is the medication that the patient is using. Then we also have the dose should be specified and the type of inhaler that the patient is taking. Well, no, we have different inhalers with different components. And then we now have 3 subsections that deals with what happens when the patient is stable. And this is very simple in the sense that it deals with like what we call the traffic light approach. He has the green, the yellow, and the red zone. And that is why this written action plan should be used with the peak flow monitoring device, which was initially projected. So when the patient is on the green zone, this means the patient is at best of their lung function performance. They have more than 80% of what is expected of them in terms of how much of air they are able to bring out. So they use their normal, what we call the reliever medication therapy, and the maintenance therapy, sometimes morning and evening. And then when they are on the yellow zone, we call it the caution zone or the alert zone. That means at this point, there are impending dangers. So the patient can have worsening of their symptoms, whether in the day, at night, they are wheezing or they are coughing, or they cannot get as much done, whether at home or at work. So at this point, in the past, we used to say they double the dose of what they used to do. They now say quadruple the dose, that is times 4 of what they use for their maintenance. And then they now use their reliever or rescue therapy as needed to relieve their symptoms. And then they continue to monitor their symptoms with the use of the peak flow meter to know whether this is going to appreciate. If at this point, their parameters keep going down, they may enter the red zone, which is the danger zone. And this is the point to actually call the doctor, to seek attention from the doctor. So this is what the plan is actually all about.
Thank you so much. You see, the other thing, I think for you agree with me that when your patients come with acute severe asthma, we always ask for a written plan. You know, we don't just talk to them. You know, there was this great man who said that reading makes a ready mind, writing makes an exact mind. And research that has been done by Harvard scholars and many other places have found out that writing actually makes things easy. I carry a notebook around with me. So we give them a written management plan, and then we also introduce them to the peak flow meter, to the volumetric. We also introduce them to all the the spacer device. We also introduce them to all the inhalers, and we also introduce them to the clinics they need to go to. So because we want them to be in charge, and especially teach them about the yellow zone, the green zone, and the red zone. We don't want anybody to get into the red zone. I can say that since we have been campaigning about asthma control in this country, we have seen a lot of people coming less to the hospital because of asthma. We've seen asthmatics taking management of their asthma, and we are looking for donor agencies, rich people in this country, to supply peak flow meters, to supply nebulizers, so that people can have asthma. Now, this is my major campaign, that every asthmatic should be well equipped. And it's my desire that I don't want to see an asthmatic die. Now, back to you, Victor. You have an interesting question which you want to ask.
Thank you very much, Prof. Just have 2 questions. My first question is on this issue of diagnosis. What level of health facility can we, ordinary man living in the rural area, be able to get the diagnosis done properly? For instance, we have primary health care, we have general hospital before coming to the specialist. Is it possible to get it diagnosed at a primary level?
Yes, I think every average doctor should be able to diagnose asthma because the symptoms of asthma are easily recognizable. You know what I mean? We'll talk about the cardinal symptoms, the pattern of symptoms, you get it, and the diurnal variations. But step 2, if we find, we also suggest that they should have some measurements to confirm that diagnosis. And that can be done in the secondary or tertiary healthcare. More than that, there's some research that talks that asthmatics have what we call subsensitivity to asthma. What do I mean by that? they say they have asthma, and they are feeling, we see them, and we feel that the asthma is not controlled, but they say they are okay. Simply because their sensitivity is poor. And that's why we have an objective measurement. And so we suggest that just looking at the symptoms is not enough. Refer them to tertiary health care where they can be diagnosed properly, and then care can continue.
Wow, thank you very much, Prof. Now, looking at your profile, you've written over 200 articles, and you have quite a lot of books you have written on asthma management. But see, all these materials are for the epistemic communities and intelligentials. I want to ask, for the grassroots people, I see at your back, last time I was looking around here, I see Asthma and Chest Care Foundation. What exactly is this foundation for?
Yeah, Asthma and Chest Care Foundation was something that was formed several years ago with a tripod stand of education, of prevention, treatment, and then recently research. It has won awards in the United States, in Philadelphia, and Georgia, and also in this country we've also been involved. The goal is to educate asthmatics, to tell them about the current treatment of the therapy, to also educate doctors, and also to raise awareness of asthma. Now, we also work in liaison with the Nigerian Society, which is also a society that is actually committed to respiratory conditions. I was once a president of that association, and the Nigerian Society have guidelines for asthma. That guidance is being revised, and we can also reach out to them. The Asthma and Chest Care Foundation publishes books like this, small leaflets, which are given free. And we run Asthma Center in Ife. Our aim now is to run the centers all over the country. Then there's a book that has been written on asthma. I don't know if it can be projected. Yes, it's there. And this is a book that is being revised, and this year I'm going to be revising them. But it's read, it's so simply written that the pharmacists, the nurses, the doctors, and the specialists can see asthma from zero to what they call hero.
Wow. Another question just cropped up. You just showed us some of this material. Is there any possibility of having these materials translated in the local languages?
Yeah,
And what sorts of fund? How do we get funds?
Yes, you see, we are a philanthropic organization. We are a non-governmental organization. Anyone that wants to support Asthma and Chest Care Foundation can. And I will pursue this project as the next phase.
Okay.
Yeah, Imafino.
Yeah, thank you so much, Prof. As a leader in the epistemic community, as someone who has given so much to the research of asthma, is there any other platform or event we can use to reach the wider society in educating them and this town-gown relationship?
Yes. Thank you, sir, because you've made it very, very, very easy for us. I am a very passionate person to say that there should be no division between the academic and the community. Academic is not about esotericism. It's not about intellectuals that are out of, touch with the common persons. I believe anything you learn in your lab, it should be applicable to your larger society. And so that is why we are doing this Asthma Day. And we're going to do COPD Day. We're going to do Pneumococcal Day. And then we have many organizations like the Nigerian Society that are always doing programs. And there are many physicians, chest physicians all over Nigeria who organized World Asthma Day. Niger, Ebonyi, Enugu, everywhere. So they start concerted effort by everybody saying that, look, we don't want to see patients coming to the emergency. We want to get them to manage their asthma wherever they are, and they want to see the local physician, the private practitioner, the secondary or tertiary doctor in the community being able to manage asthma. And even the pharmacist being able to diagnose it and cooperate together in one they want to submit, and the nurses too, all involved in this program. Yeah. I don't know if I can now take a few questions, run that have been given online, and then we can as well call it a day. Now, Faye, can asthmatic patients do any form of prevention to prevent their future children becoming asthmatics?
Sir, like it was earlier stressed that asthma does not really follow, although it has some genetic components, does not really follow the Mendelian pathway of transmission. So that means if someone has asthma, it doesn't invariably turn out that the children are going to have asthma. But that being said, if there is a family history of asthma, that puts an individual at an increased risk of asthma. So that means a lot of things can be done in terms of the environmental control. Those are the nature that was actually spoken about, the trigger factor. So we have control over those. So avoiding those triggers can help in an individual who has genetic susceptibility to asthma.
Yeah, in the past we used to talk about what we call hygiene hypothesis. That children who are born in dirty environment and they use antibiotics, they tend to have prevention from asthma. They take a whatever the type 1 thing, and then those who are placed in places that they have, clean environment, they don't go to daycares and so on, they tend to be more susceptible to asthma. But I think the mother should not smoke. The father should not smoke. Don't increase triggers in your environment that will make your child smoke. And that will make your child have asthma. So those things you can do. And as a follow-up, I want to ask if asthma is hereditary. Yes, it is genetic, but I told you it's not Mendelian fashion. How can a pregnant asthmatic patient be managed? One sentence.
The management of asthma in patients who are pregnant who have asthma follows the normal plans with individuals who are not pregnant.
Yeah, just manage them normally. Most asthma drugs are safe, so manage them. Now, they say, can you demonstrate the peak flow for us? How it can be used? And we want you to do demonstration, please.
This is the peak flow.
Please focus on that. Focus on that. Go on.
So this is the peak flow meter, which is an important tool, simple to use and cheap. So every patient with asthma should actually have this. So what it does is that it helps to measure what it calls the peak expiratory flow volume. That is how much of air you can quickly bring out as fast as possible. If you look at this, there is a color code to it. I don't know whether that is so visible. You have the yellow, the green, the yellow, the red zone. And then there's something that looks like a cursor, something that can be adjusted up and down. So for this to be used, one, you have to move this red arrow or a cursor down to the minimum marking. So there are calibrations on this peak flow. So you adjust it down to the lowest level. And then this should actually be used in the morning and in the evening. So this preferably early hours of the morning. So you can assume a comfortable position. Either you want to sit comfortably, rest your back on the chair with your 2 feet placed on the floor. Or if you want to stand, you are comfortable with stand, just like when we do spirometry. So being placed at the lowest portion, so you breathe in and out to exhale the air in your lungs at first, and then you take out in and air deeply. And afterwards, this should be positioned and put in the mouth. There is an opening here. So you seal up the mouth around it, and then you forcefully blow at once. So this cursor is going to move to determine how much of air you are forcefully breathe out. And then the marking should be recorded. This should be done on the minimum of 3 times, and then to record the maximum score. That is in the morning. Then in the evening, some settings.
Is it before medication or after medication?
That is before medication.
Okay.
That should be done before medication. So some say it is best done in the evening, around 4 to 5, but take a comfortable time that you are going to be constant with, and then follow the same process. The cursor bring it down to the lowest portion of the markings, and then assume a comfortable position. Seal up your mouth around the opening, and then forcefully blast out at once, and then take note of the recording. Do this at about 2 to 3 times, and then there is a chart that comes.
Yes, get on the chart. Let's see.
There's a chart that comes because the essence of the peak flow meter is to measure what we call the diurnal variability. That is by how much the amount of air you are able to bring out in the morning and evening, how much does it vary from each other. And this helps us to monitor how much of airway responsiveness such an individual has. So the chart comes with the peak flow meter. You can make photocopies so that subsequently you can have a lot of readings. So, and on the chart, there are markings, there are dates that you can put the date. So Sunday to Saturday, so you can put the date, and then there's something that looks like a graph. So your readings in the morning, I said you can do 3 and then pick the highest point and the highest score, then you plot it on the graph. Then also in the evening, so there's a marking that shows the sunset. So you pick the highest reading out of the 3 blobs and then record it. Each of the clinic visits, a patient is supposed to come with this, so the doctor will be able to look at the tracing and then decide how much the person is doing. And then if at any point you notice even before coming to that there's a dip, that is sometimes very different from all the other, that can also be a pointer that maybe something is about to happen.
Thank you very much. The other thing I want to say about the peak flow meter is that it is simple, less expensive, personal. Now, in the past, we used to say that the normal depends on the age, your height, where you take it, the environment, whether on the hill or this thing, your sex, and so on. But now we tell people to look at it in terms of their best peak flow. That is the one you have when you have no attack. Or I don't like to use the word attack, when you have no asthmatic episode. Then you now use it to compare. So we now call it peak flow rate, your best value, and we use it to compare whenever you have situation. Now, the other question here is, what is the first choice inhaler in the management of acute asthma? There's no first choice inhaler. Acute asthma is managed in the hospital. You use what they call bronchodilators, the beta-2 and the anticholinergics. You use oxygen, you use steroids. And when the patient is not doing well, you go second. What is the role of oral salbutamol, as some patients claim that it has helped to control? To me, it has no role. We don't encourage you to use oral salbutamol. One, because it's very erratic in its behavior. It can lead to palpitation, your heartbeat, it can lead to tremor, and also it can also, it's erratic in its use. We want to get at the airways, inhalers are the mainstay. Then there's another question here, which is, what vaccines are necessary for asthmatic patients? Now, you don't get vaccines used for asthma. We don't have got a vaccine for asthma, but patients who are asthmatic, especially the elderly patients, need to be given certain vaccines to prevent infection, which are being said to be used to cause triggers. And then pneumococcal vaccines are important, and H influenza are important. How is the spirometry interpreted? Where it's difficult for me to do that now. Where when you blow through a spirometer, you get what you call the forced expirative volume in 1 second. And then you blow out and keep blowing, it gets a curve, you get the forced VC, forced vital capacity. And the ratio between the FEV1 and FVC gives you the vitality ratio. And then that ratio, 70% is normal. And then we'll say between plus or minus 20 up, plus or minus 20 down. We can easily interpret it. So from that, we can have an obstructive disease or restrictive disease. What species in food can trigger asthma? What kind of food can trigger asthma?
Spices.
What? Spices. Well, I think a woman should tell us, what spices do you put in food that can trigger asthma?
Well, I'm not quite sure there's any particular spices, but some have said that our food can trigger asthma, especially those who have allergies to food. Dairy foods, nuts, in fact, some seafoods too can also trigger asthma, especially those who have allergies to food. So those are the kind of things, but it depends. You also actually have to know what are the things that trigger. So there are some idiosyncratic changes. Some may react to some spices, and also, but in specific there are no actually maybe scientifically proven spices that can trigger asthma?
Yes, is the nebulizer powered by battery? They're battery driven. They're also electricity driven. Can we have demonstration? Well, we'll not be able to demonstrate it now in this place. Now, there's another question you asked. What is the difference between COPD and asthma? Now, COPD is called chronic obstructive pulmonary disease. Now, we don't diagnose COPD except in those who are above 40. Why asthma is a genetic disease, COPD is an environmental disease. And so those who have COPD are those who are either exposed to indoor pollution or they are frequent smokers, and they now have disease. They are elderly, and one big difference between the two of them is that in COPD, you must identify a noxious agent which is responsible for the situation. The treatment also differ in a sense. In COPD, beta-2 agonists, long-acting beta-2 agonists are central, while in asthma, inhaled steroids are central. In COPD, the patients have, well, some form of what I call allergies, but it's not as important as in asthma. In asthma, about 60 to 70% of them have allergies, but in COPD, it's not. The predominant cells in asthma is eosinophils, but then in COPD, the predominant cells may actually be neutrophils. In COPD, vaccine is an important management, and also we want to rehabilitate them, and also want to give them antibiotics, apart from giving them drugs to open up their airways. And oxygen is central in the management. That differs from patients that have asthma. So one major thing you should notice is that there are some patients that have asthma and also COPD, what they call the asthma-COPD overlap. But basically, COPD is for the elderly, it's progressive, it is cough and breathlessness. Most of them has an inflammation, and they would sometimes move on and move on. If they're not well controlled, it can lead to difficult challenge in their health. So that's the difference. Now, before I conclude, I just want to show you a few things here, and then we can conclude. Now, okay. So let me get this. How do I get this in up here? Let's get this thing. Let's get it here. Yes. Okay. Now, there are some category of asthma which is called severe asthma. That's different from acute severe asthma. They're about 5 to 10%. These patients are refractory to normal drugs, or they have suboptimal control to their asthma. So this kind of patients, sorry. What's that? Okay. This thing's not moving forward.
Enter.
Now, if you look at this slide, acute is on this side, which shows the acute case, that is what you find, and it's inflammation. But chronic case is that the airway diameter changes, what I call the airway architecture. Because they are not well controlled, there are a lot of things that happen to the airway and actually close the airway. So we don't want the patient to have this chronic change in his airways. And that's why we suggest you manage him properly. Now, consequences of asthma. It can always lead to frequent emergencies, visits, chronic fatigue, presenteeism, you come to work but you are not there, absenteeism. It can also affect musculoskeletal changes in children. It can lead to, there can be complications of medication, and there are other associated diseases. It can decrease your quality of life, and it can give you severe psychosocial problems, and also economic problems. Now, there's what we call phenotype and endotype. That's what we are now thinking now. Phenotypes are the things we observe in the individual and are measurable by things like the peak flow and spirometry. The endotype are the things that drive the disease, what we call the pathophysiological mechanisms of the disease. So you can simply find out that phenotypes is the observed clinical characteristics, while the endotype is the mechanism that causes it. Now, this is a very complex side. Now, because of this, the study of the endotypes, we know a lot of drivers to this disease. Either they are upregulated, as you can see from the airway, or they are downregulated. So nowadays, to treat asthma, when it's very, very severe, very small set of people, we use biologics, which aim at their various pathways to treat them. I won't go into that because that will be for, and this is all you find, various things. And we have discussed this in our previous asthma thing. Now, there's something I just want to show to us, which is important. These biologics are going to soon be standard management around the world, especially for asthmatics. But I want to just show you one more thing and close this important slide. This is for consultants and residents among us. Now, before we used to treat asthma empirically, one treatment for all. Later, we moved to stratified medicine, in which you say different treatment for each group. But now we are now talking about personalized medicine. So for your asthmatics, you must study them, know their phenotypes, know their endotypes, if possible, and then go for precision management. Now, I tell people this, your step-ladder management: confirm the diagnosis, assess the patient's control, check the adherence to treatment, confirm adequate inhaler use, and then also look at the differentiation between a severe asthma and just a chronic asthma, then treat appropriately. The symptoms, you must know the cardinal symptoms and the pattern of symptoms. And then you must also look at precipitating factors, which you mentioned. Common allergens are dust, exposure to pests. I know somebody who kept on keeping pests and actually led to severe asthma in one of his children, and the consequences were bad. Smoking, obesity is becoming a problem in asthma, sinus problems. Now, what are the things that can mimic asthma? Foreign bodies. But the difference between foreign bodies is that it blocks epithelial bronchus, so it is unilateral, it doesn't spread over. Cystic fibrosis, we don't have it commonly in this country, where I won't say we don't have it commonly. Pediatricians will tell me I'm wrong. We must know that it's usually condition that can affect both the chest, the GI, and mucus. Then the upper airway cough syndrome. Those are not asthma. It gives you sneezes, itching, and throat clearing. Congenital heart disease, bronchiectasis. The important thing about bronchiectasis is that there is recurrent chest infection and there's production of sputum and halitosis, foul breath. Then COPD, I've told you before then, heart failure may mimic. In those days, we used to tell people what is cardiac asthma, what is bronchial asthma. Cardiac asthma, you can diagnose it because you do your ECG, you do your echo, you do your chest X-ray, and then mainly it is due to left ventricular failure, and wheezing is not usually universal. And then the treatment in this particular patient is not salbutamol. Tuberculosis, easy to know, loss of weight, hemoptysis, night sweat, and contact with chronic cough. Now, we have been talking now for about 2 hours, just about short than 2 hours, about asthma. Asthma is a heterogeneous disease. It is a disease that presents as symptoms, but there is the underlying pathology that gives us the symptoms. Now, this asthma needed to be diagnosed not only from symptoms, but from physiological measurements. Every asthmatic should have a form of care. Should know about his asthma. He should know about his triggers, He should know about the components of his asthma. He should know about the peculiarity of his own asthma. He should know about the things that causes exacerbation. He should have a peak flow meter and know how to manage it. Some years ago, I was in Tromsø in Norway. A few experts met together to look at the M-Health as the use of managing diseases. And I presented the paper on COPD. So somehow, your doctor can teach you how through your phone and the peak flow, you can actually know how to manage your asthma. It's being developed in many parts of the world. So I want to say, as we conclude, I want to thank all of you for being in this audience. Thank those who have shown interest in this meeting. Thank you for spending your time to listen to us from all over the world. To say that asthma is a disease that can be vastly controlled. No one needs to die of asthma. The drugs are, although not too affordable, but then we have it now in Nigeria. There are companies that are getting it. We also want you to know how to use it and then to have a self-management plan for your own asthma. Asthmatics can be anything in this world, so don't fear. Encourage your children that they don't need to fear. Questions are being asked, if I have childhood asthma, can it be cured? I'm not a pediatrician, but we used to think there's a rule of thought. One may appear silent, another one may come up later in life, and some may just be stable. But we do not say that you can cure asthma. You must be alert. Some say in pregnancy, can it be? I also have a rule of thought. Some it can be increased, some it can be decreased, some can remain stable. The symptoms and the presentation are also important. You can always contact us in the Asthma and Chest Care Foundation, look at our website, and then you can also contact physicians or pharmacists around you who will educate you. The Nigerian Thoracic Society, you have a secretary and the president who can always reach out to you and help you to identify chest physicians in your locality. I want to thank everyone for being here. I want to thank the erudite Dr. Victor Okorie for being here with us. I want to thank the business guru and publicity analyst, Dr. Imafido. Thank you so much for the interest you have taken.
Thank you, Prof.
I want to thank our erudite scholar, Dr. Feyi Kehinde, who has made this work so easy for us. Let's clap for her. I want to thank Dr. Afolabi, also who has given us practical things on how these things shall be treated. I want to thank our crew, Muiwa. I want to thank Daniel Popola. I want to thank Feromi. I want to thank Patrick and all his people. If you look at here, it's as if we are in a war front. They are shooting us on both sides, in front and the back. I want to thank my dear wife, who happens to be somewhere in the audience, for coming to ground us. I want to thank the residents who came from the hospital to join us. Yeah, my wife is being shown, the beautiful lady. Show her again, show her again, show her again, show her again. Show her again, show her again. Yeah. She's laughing, she's laughing. Yes. So I want to thank everyone. I want to thank the Pharmacy Association of Nigeria and also the community pharmacists and pharmacist Lawal for her push, the Omeron for their support, Jess Pharma, Pfizer, and every other person that have supported us in this program. I want to thank the Asthma and Chest Care Foundation for what I've been involved, and my personal staff for being here. Much more than that, as all of you know, I'm also a preacher of God's word. I want to thank the Almighty God for whose grace and power we are all living. Without him, we can't do anything. And with him, there is nothing impossible. I've always said, out of the broken pieces of your past, God can build an edifice of hope. There is no hopeless case in God. Use your medications, know about your asthma, and things shall be well with you. Thank you very much. Until we see again in the next program, please go to my YouTube to see other programs I have, Greg and Rabo podcast. Thank you very much. Let's clap for everybody. Thank you very much. Okay. Yeah. Yeah. Lord, we thank you for this program.
Thank you, Jesus.
Bless you. Give you glory. We'll give you the honor in Jesus' name. Amen. I think we have some snacks for, I don't know if you go around, but just wait. What are the drinks? Is it in the fridge? Eh? The drinks in the fridge. Go and bring the drinks now. Go and bring, go and get this. See, go and bring the snack. Go and bring the snack. Go and ask.
Okay, for your own school.
Go and bring the drinks.